And I think we're going to have to skip the break, folks. So we understand if you have to leave for a few minutes because we are kind of running a little overtime. So we'll go to Tracy with some questions. Tracy, do you have any questions for us?
Okay. I, I was trying to unmute myself, but I had to wait for official approval to unmute. Okay, so I wanted to provide a question and answer myself because it was about the Speakers Bureau from McKinsey's mission. I got a question offline, and I just wanted to mention there was a question about whether people, caregivers, can do the Speakers Bureau instead of the patient, if maybe the patient is not in ideal health. And the responses from the medical schools, this is the response that I received from McKinsey's mission, is that the medical schools have a strong preference for hearing from the patients directly. Yeah, and so McKinsey's mission is open to having both the patient and the caregiver present as a team. And they're building their library, and this may be best use of the caregivers at this point, but they've done some video libraries, and you can reach out to them. I posted the Speakers Bureau McKinsey's mission email in the chat box. It's, if you want to skim through there, it's ASB for Amyloidosis Speakers Bureau, .mm for McKinsey's mission, 713@gmail.com.
Thank
Okay.
you.
Okay, so the first question. So let's get to the questions. So I'm looking through the ones and looking at what's voted. And first one I have is, due to the fact that some AL amyloidosis are finding that stem cell transplant or chemo or both do not necessarily stop the active disease, can we count on drugs such as the CAEL 101 or other monoclonal antibodies alone to be the best line of treatment in the future? If so, of course, any idea when this would be available to the patients? Because we also had some other, a similar question asking if the stem cell transplant was still the gold standard.
Okay, well, that's actually two different questions. So let's get to the
Yeah.
first one. Can the Calum antibody, if it's assuming it's successful, could that be used in place of treatment if the treatments don't work? So let's ask Dr. Landau, and then we'll ask some others for opinion.
Am I unmuted?
Yes.
Yep.
Hello? Okay. So thank you so much for that question. As I mentioned in your in the talk, the KAL 101 drug or antifibrillar antibodies or fibril-directed therapy by themselves are not enough to as independent therapies. They require, you first have to or simultaneously have to shut off the factory that have plasma cell directed therapy to shut off the factory that's producing the abnormal light chains, which misfold and deposit in the organs. The monoclonal antibody against the fibrils are an adjunct to that treatment to try to accelerate organ recovery.
Okay, and Dr. Sanchirwala, let's get you piped in on this one. The part of that question was, is the stem cell transplant still the gold standard?
So stem cell transplant, as Dr. Landau has already mentioned, that is available for only about 20% of patients who are diagnosed with AL amyloidosis because of significant advanced cardiac involvement, because of poor performance status, because of advanced other organ involvement. So despite us feeling that stem cell transplant has the highest rate of achieving hematologic response and organ responses and improving survival, it is not the treatment of choice for majority of the patients who are diagnosed with AL amyloidosis. There are no randomized clinical trials of stem cell transplantation with non-stem cell transplant regimens, except for one reported in 2007 in New England Journal of Medicine from the French group, which had its own limitations. So again, I think it is not a very well answered question yet.
Okay, great. Let's get one more. Let's get some 2 cents worth in from Jacques from Florida at the Cleveland Clinic. on the stem cell transplant. Do you consider it the gold standard, something if 20% of your patients qualify, is that something you'd want to do for them?
Am I unmuted, Muriel?
You're there.
Okay. When if the patient is eligible for stem cell transplantation, that should always be a consideration. If the comorbidities and organ functions are not the prohibiting and limiting factors, and if the patient is interested, stem cell transplantation should always be considered. And again, as we discussed previously, there is no standard of care in AL amyloidosis yet. Participation in a well-designed clinical trial with high scientific merit, when available, should always be the first consideration for treatment of AL amyloidosis.
Thank you. And let's hear from Dr. Kara Rosenbaum. Dr. Rosenbaum, who's also in New York City, is stem cell transplant your go-to if the person qualifies or meets the criteria?
Yes, we still screen everyone for upfront a diagnosis for stem cell transplant, and typically we are looking at responses after a brief induction to see their degree of response. But if we are certainly seeing less than any delay in response, less than a VGPR, and they are stem cell transplant eligible, we move to stem cell transplant at this time. There's some discussion for patients who are may have a poor performance status, who may appear to be responding month to month early, where we may delay and watch them on treatment if they are responding.
Okay, well, thank you. Let's hear from Jeff Zonder in Detroit. Dr. Zonder, what are your 2 cents in this?
Can you hear me?
Oh, yeah.
Good. Well, I agree with the things that have been said thus far. Most patients, unfortunately, aren't great candidates for transplant, but those who are more likely to enjoy a sustained response and durable benefit from that therapy compared to regimens like CyBorD. That may change with the addition of drugs to the CyBorD regimen, like daratumumab, for instance. I mean, we don't know the results of that study yet, but if we're able to get deeper responses with non-transplant therapy, those responses may end up being more durable. If certain drugs become used in a maintenance fashion, that may also extend responses. I mean, right now, the advantage of transplant for that minority of patients is the durability of the response. And so until we have non-transplant regimens that are more like that in terms of long-term outcomes, it seems reasonable to transplant those patients whenever possible.
Oh, great. This is a great opportunity to meet all of our hematologists on our panel. So next we'll go to Dr. Robert Vestio from California. Dr. Vestio?
Thanks for asking me. I mean, I think I would agree, with what everybody's said so far. I think the main advantage of the transplant is that when it does work well, it can work for a really long time and a really long time without any need for other therapies. So there's a lot to be said for that. But many patients can't tolerate a transplant. And then some patients are lucky and do profoundly well with the standard treatment. And when things are going well and they're tolerating treatment, it's hard to change a good thing, and they can just be watched.
But do you like that enduring response they can get evidently from the stem cell transplant?
I do. I think, I would probably do it if I had the choice.
There you go. Okay, and then we have Dr. Saji Kumar from the Mayo Clinic in Rochester, Minnesota. So Dr. Kumar, can you unmute yourself and or someone can unmute you? I don't know how we're working that, so we can hear your 2 cents in this.
Sure. Thanks, Muriel, for organizing this. I think transplant still plays an important role, as was pointed out by Vaishali. Clearly, it's a small proportion of patients who can get it, but as has been highlighted by many, it does give very durable responses for those patients who can go through it. And one thing I just wanted to highlight is that in a lot of the literature has the data on the very high mortality or high side effect burden associated with transplant. And I think that's an experience from the past. And the more recent years, we have been a lot more selective in who can be taken up for stem cell transplant. And with that approach, we clearly have significantly less morbidity associated with the process and the mortality especially. So yes, for selected patients, it's a great therapy. But of course, for the vast majority, we have to rely on something else.
Thank you. What is that behind you? I was picking on Dr. Wall's wallpaper before, but what is that behind you against the wall, that tallish object?
It was a guitar which I long years ago tried to learn, but gave up a long time ago.
Okay, thank you so much. Okay, and last but not least, we're going to hear from Dr. Suzanne Lynch from Columbia, New York. So Dr. Lynch, let's hear from you on the stem cell transplant. Let's hear if it's something you like to go to for enduring response, if you have a limited number that qualify, or if you don't like doing them at all. Let's hear that.
Yeah, as of now, we still favor transplant in patients if they are transplant eligible. But I see in the future that we might really change and come away from stem cell transplant and to other therapies. Venetoclax is so potent for many amyloid patients with translocation 1114 that we might even consider to use those potent drugs up front. Dara also. So I'm not sure whether in the future transplant will really play the role it plays as of now.
Very interesting. I recently saw a study comparing venetoclax to bendamustine. And they favored venetoclax over bendamustine. And that Dr. Landau was talking about the alkylator bendamustine, and she briefly talked about venetoclax. Can you talk about that for a second?
Yeah. I mean, remember, we just published our bendamustine trial, but this trial started in, if I remember, 2010 or 2012. At a time, we didn't have DARA, we didn't have venetoclax. So bendamustine, I would say, is a drug that really played a major role at a time we didn't have the, I would say, novel treatments. We did a retrospective study, and we are about to publish that with venetoclax in patients with relapse refractory AL amyloidosis, and the response rate is really stunning. So I see that especially venetoclax in patients who carry the translocation 1114 will play a major role. Remember, amyloidosis is not a cancer per se, it's an aggressive plasma cell clone. It's usually a small population of plasma cells that behave pretty benign, like an MGUS. So I think that the cells do not really need a lot of aggressive chemotherapy in order to, I would say, induce a remission in most of the cases. So with targeted therapies, we might have a tool to avoid, I would say, kind of, more aggressive regimens.
Well, venetoclax got a bad rap last year. Something about, can you tell us about that and how they fixed that up a little bit?
Yeah, nobody knows exactly. I mean, there was a study that, and Shashi Kumar can probably talk much more about that. It was a study that showed that patients, multiple myeloma patients treated with venetoclax, had a decreased overall survival. The patients had response, and they responded, and they didn't die from progression of multiple myeloma, but they had other reasons to die, infection, for instance. There was not a clear signal, but what I think is that this potent drug really wipes out your plasma cells, the healthy ones and the not healthy ones, decreases the antibody production, and that the patients have an increased risk of infection, life-threatening infection. They might die at the end from cardiac failure, but I think that was one of the problems. So when we give venetoclax or very potent drugs that inhibit plasma cells, also daratumumab, and we see that the immunoglobulins are low, we really need to keep an eye on that and replace it, for instance, with IVIG, because especially in patients with renal amyloidosis, where they have a lot of proteinuria, this is a high risk.
IVIG, for those of us who don't know what IVIG is, you have to tell us now.
Yeah, intravenous immunoglobulins. So you replace kind of, the loss of, I would say, your healthy polyclonal antibodies, which you usually produce by a donor who donates healthy immunoglobulins, and it helps you to fight infections. The problem is those antibodies only last for around 4 weeks, and you have to give those, or you have to get those treatments at least monthly.
Okay, and Dr. Kumar, you were referenced in this discussion about the venetoclax, so can we get your last word on that?
Yes, so the trial that is being referred to is the Bellini trial that looked at venetoclax in combination with bortezomib and dexamethasone, and this was in the setting of relapsed myeloma. What we found in that trial was that the patients, even though there was a better progression-free survival and good responses with venetoclax, there was a subgroup of patients who appeared to be at higher risk for toxicity with this combination. And it seemed to be mostly patients who don't have the 11-14 translocation, and the ones who may also have low levels of BCL2 expression, which is the target for the venetoclax. So about 30% of those patients did not really benefit. In contrast, may even have been harmed by the combination. We don't know how that, it's probably not going to be as much of a problem in the amyloid setting again, because we may be able to do without combinations, and again, a higher proportion of patients already have 11-14 translocation, and the ongoing studies are particularly targeting that subgroup of patients.
Okay, thank you. Tracy, what's our next question?
Okay, I would just comment, Muriel, I don't know if we want to try to get to more questions. We have almost 80 or so questions, and we only asked 2 so far.
Oh, I'm sorry. All right, we'll speed
I just
up.
think, I think we do need to go around and ask different, we need a balance of discussion and also getting to questions would be my feedback.
Absolutely. Let's have a cardiac question for our brilliant.
Yeah, that's what I was going to do, a cardiac question. So just for, we're all learning. So the next one I have is NT-proBNP effective in monitoring heart involvement if the patient has damaged kidneys as well? Should BNP be used for patients who have both heart and kidney? So how do we monitor that when we have both?
Well, let's start with Dr. Ruberg, who did our cardiac presentation, and then we'll go through our cardiologists so everyone can meet them.
Sure. Happy to answer that question. It's nice to jump in. So the question was, can you use NT-proBNP for following cardiac involvement in somebody with kidney disease? That's a very good question. And I don't know if I alluded to that in my presentation to great detail. When the kidney function becomes impaired, the values of those cardiac blood tests get higher because those cardiac blood tests are removed from the circulation by renal filtration or kidney clearance. So they become much higher. And the 2 numbers that we generally look at, BNP and NT-proBNP in that family, they actually respond differently. I mean, some of the NT-proBNP goes much, much higher than BNP, and it's appears to be much more dependent upon renal clearance. That being said, even if you just kind of take out the kidney dysfunction in general, we still think these numbers provide excellent information on prognosis. And so kidney dysfunction doesn't really figure into our staging per se, but we reported some information, and others have as well, looking at the value of these numbers as they change with time. We generally believe that, as I said in my presentation, a 30% reduction in either BNP or NT-proBNP connotes a cardiac response. But you have to take it with a grain of salt. If the kidney function is worsening, we have to look to other measurements of heart improvement, because as you kind of astutely point out, as the kidney function worsens, our ability to interpret those heart blood tests becomes more and more impaired.
Well, I didn't astutely point it out, but somebody did. So thank you. Well, let's ask our nephrologist before we continue with our cardiologists. Dr. Havasi, can you unmute and give us the nephrology 2 cents there?
Dr. Ruberg summarized it very nicely. So it's less reliable, but they can still sometimes make out of something. So sometimes it is helpful, but unfortunately it's harder to interpret.
Okay, and let's hear from Barry Trachtenberg.
Hi, yeah, no, it was nicely summarized. Not too much to add. We do still use it. It is especially NT-BNP a little bit more limited in patients with advanced kidney disease, but we still do track it.
Thank you. And Dr. Brett Sperry?
All right. I agree. I mean, I don't have much to add to the other folks. You know, I saw someone this past week who had renal AL amyloidosis and really had minimal cardiac involvement, but because of the renal dysfunction, you know, had elevated NT-proBNP and troponin, and then he ended up on dialysis. And actually, with treatment, he had a biomarker response. And so I don't think that's necessarily from improvement in his cardiac dysfunction, but rather from improving, his clearance and his renal function. So I think it's the only thing we have at this point to look for, or the best thing we have for biomarker response. But yeah, definitely can be confusing in patients with renal failure.
Great. I hope your kids haven't locked you out of the bathroom recently.
not again. Yeah.
Okay. And Dr. Walensky, can we hear from you? We are having a problem hearing Dr. Walensky. Okay, we'll move on. We'll come back. Okay. And basically, I just wanted everyone to see our cardiologist, because if you have more questions, we can direct them directly to them. Okay. And Dr. Patel from Cedars-Sinai in LA. Dr. Patel.
Thanks, Muriel, for organizing this. I think the trending of BNP in renal dysfunction is very similar to trying to interpret light chains with renal dysfunction for AL amyloidosis. And for us, generally, a long-term trend is very helpful. We also look at non-biomarker metrics, such as how the patient is doing, their functional capacity, and sometimes the echo can also help, just at least not seeing any progression of disease on the echo. And there is some literature suggesting that in the long term, echo parameters such as what we call strain pattern can improve, and even the wall thickening can improve, although on an individual patient level, that's not very helpful.
Okay, great. Thank you. Now, let's hear the next question. Tracy, what have you got?
Okay. So I have some about, I'm trying to remember how to say it. Is it Kale? Kale 101?
Kale 101. Kale 101.
Kale. Okay, I can remember how to say it. So Kale. So the question is why would the Kale 101 study exclude those already treated or being treated who have as their major threat to quality of life the amyloid deposition and not the light chain absolute value or a kappa lambda radio difference? So we have somebody who has a hematologic complete response, but still has issues with cardiac, larynx, GI tract, and amyloid deposits. And as both a patient of AL and a hemoncologist, they think this exclusion is not in the patient's best interest.
Okay, Michael Spector, I keep promoting you, right? Are you there to answer this question? Can you unmute?
Yeah. So thank you again for the participation in this. And one of the most challenging, I think, decisions we make as a company is who to include and who to exclude from a trial. I will perhaps ask others on the panel to talk about the heterogeneity of the disease, but one of the challenges is as patients progress in the course of their disease, patients become different in where they are with hematologic status, progression of their disease, progression of their organ dysfunction, and we add a lot of confounding factors. The ultimate goal of our clinical program is to answer whether Kale 101 has an effect at improving organ function and overall survival in a reasonable time period. And as we add confounding factors, patient populations that are very different, it becomes very difficult in a time period that makes it accessible to potentially make a product accessible to the broadest population possible. We are looking at additional trials to look at patients who are currently undergoing treatment or are at a different stage in their treatment. But the goal of our treatment right now is to get an answer as to whether this treatment works so we can make it available to the broadest population. It may be worthwhile for others to talk about the heterogeneity as patients progress and how difficult that becomes in a clinical trial and trying to tease out whether there's a signal of a drug effect or not.
Let me ask you a question. When you're presenting your data to the FDA to try to get your drug approved, would they be more interested in the newly diagnosed, the treatment naive people and how they're doing, or would they be more interested in seeing the results of the study from the people that have already achieved some sort of hematological response and still have organ involvement? Which does the FDA want to see?
So the FDA wants to see benefit in the overall population. Within the course of our trial, patients will progress hematologically. They may switch hematologic plasma cell dyscrasia therapy. But the challenge becomes that the main, for a plasma cell directed therapy, the main target is to lower the plasma cell production, and that's easily measured. For a drug today, without adequate imaging and ways to understand what's happening with the heart and amyloid around the heart, overall survival becomes the endpoint that the FDA most wants to see for an anti-amyloid agent. As you look at the previously treated patients, I think we know that as patients who do well in their first year tend to live for a long time, and therefore having a study with survival, you could be out 5 or 6 or 7 years if you don't select the right patient population. We're seeking to get an answer as to whether KAL-101 works in an 18 to 24 month period, which means we need to narrow the population to the population where we believe we can most see a signal and a drug effect.
So in other words, with the newly diagnosed patients with cardiac involvement, if they were diagnosed late or misdiagnosed and they have cardiac involvement, they're the most vulnerable group, and you may see, unfortunately, some very bad results for them in the first year. So that would be a better group to show to the FDA, look, half of them, the half that had the drug lived and the half on the placebo did not. So you'd be able to show that better rather than with the group that we have here watching this program that have already achieved a response of some sort.
And we believe that the effect would be more pronounced early on as well. So we'd get a very early signal within that population. But we do believe, based on our discussions with the FDA, that it's possible with the trial that we're undertaking right now, that it could lead to a broad approval, not just in the newly diagnosed patients. So we're hoping by studying the way we are that we have a drug that could be accessible to everybody in the most rapid time period.
So when do you project a trial for the people that have already been diagnosed and have been on treatment and are in complete response but still cardiac issues? When do you project that trial to open up?
Well, it's an ongoing discussion. There are people on the panel that I've had some discussions on about further trials. Our focus on this point is getting an answer on the treatment and its effect. But I would say in the coming years, we'll certainly be assessing, and hopefully in the next 12 to 24 months, we'll think about it. But our priority is on getting an answer in the phase 3 studies that we have ongoing or going to commence in the second half of this year.
Where do you find or where would a patient find the qualifying criteria? Is there like a website that they're just going to the clinicaltrials.gov to find the quality?
Yeah, and there'll be a protocol, and certainly in the United States, we expect, I think, approximately 30 sites. So they should be well distributed where a patient can visit a site and understand the qualifications within the protocol. But certainly, as we progress in this year, we're looking at a September, October start of our studies. The COVID-19 pandemic, makes it difficult at some facilities to progress a trial this year, and we're assessing that at the moment. But we believe we'll have sites in the U.S. open in the 3rd to 4th quarter of this year. And so by the middle of this year, we should have the clinical trials indicator on publicly available.
Some patients have asked if we can go overtime, Tracy and Bob. Can we go a little overtime on the Q&A so we can get more questions in?
I think that's up to all the panelists and people who are attending. I mean, we still have 80 plus questions, Meryl, so I'm not sure really going over is gonna get us to the end.
Okay, doctors, whoever can hang on, that would be really helpful, okay? Okay, let's have the next question.
So about the imaging that Dr. Wall covered, I mean, we talked a little bit about the kidney impact, but one of the other questions was, what about the risk? Is there any risk of the radiation imaging related to maybe future cancer or anything like that? And has anybody had any? That was one of the questions.
Dr. Wall?
Yeah, that's a great question. And so from the first 3 patients, we were able to calculate what we call the dosimetry for the whole body effective dose. And that's a measure of how much radioactivity your body will receive as part of the scan. Of course, every patient's different. And so the more amyloid you have, you might have a slightly higher dosimetry than somebody with less amyloid. But when we calculated those numbers, the dosimetry was very comparable to some of the other nuclear medicine scans or protocols that you get for example, a thallium scan or an FDG scan with a high dose CT. So the dosimetry is not higher than what's out there already for a lot of nuclear medicine protocols.
And did you, I know you showed some of the different imaging and such. Did you also include, I know we saw spleen and kidneys, but was there also GI? Did you have AL patients with GI involvement?
So yeah, the GI is difficult to interpret for a few reasons. When you do GI biopsies and you show there's amyloid there, there's often microscopic deposits of amyloid, which are difficult to image by PET imaging. The other issue is that the walls of the GI are very difficult to see, so they're not very thick. So in the PET system we're using right now, it's difficult to see those regions explicitly. And then the third complication is when the peptide is being cleared through the kidneys, what happens is some of the iodide comes off the peptide, which is a good thing in retrospect, actually. But the iodide goes back into the circulation and then is taken up by the stomach and then slowly leaches through the GI tract. So those 3 factors make it difficult to unequivocally say that you've got positive uptake in the GI. Some patients we can say it, others it's difficult to say with certainty. But the nice thing about the GI is it's an easily accessible tissue to get a biopsy from to confirm by microscopically whether you have amyloid there. So yeah, it's tough to see the GI, but we can see it, but it's difficult to interpret sometimes.
Okay, thank you. Another one, I just let these move around, so sometimes I lose them, but maybe back to the KL. There was a question about whether the amyloid, is there a decrease seen in the amyloid deposits in the salivary glands or the tongue with the KL-101?
So at this point, there hasn't been localized studies. It's something that we're considering. So, if the hypothesis plays out, you may expect to see a localized reduction in amyloid, but KLM hasn't conducted any studies with respect to localized amyloid at this point.
Okay, thank you. I have one actually, Bob, I have one for you related to the registry. The question, I think it's a really good one to share with everybody regarding security. So there's a question of privacy, I should say, not security, but there was a question about the privacy of the data and HIPAA compliant factor, for example. Did you want to say a few words about that in regards to the registry?
Well, it is all compliant with HIPAA requirements. I mentioned a couple of things. It's almost a few different aspects to that question, but yes, we are complying with the HIPAA requirements when we start to actually have medical data that is subject to them. The people who put in the data into the registry right now, the registry itself is not actually subject to HIPAA requirements because the data we're collecting isn't specifically medical data from a physician So while we are observing HIPAA requirements, we're actually not subject to them as of yet. When we get to the point where we're actually able to have electronic health records, then more of that will kick in. We do have an IRB that we have to report to and we get annual approval from for the way we're handling the data. So to that extent, we're compliant with those requirements. From a security perspective, we are instituting two-factor authentication, which is what many of you out there would probably already use for things like bank accounts and the like, just to ensure that anybody who's that if you're logging in, you're logging in as yourself, and no one is going to log in as you because of that extra authentication step. And the system that we're using is always trying to make sure that they're at the high end of data security. I think with any of these databases, as everybody knows from things that have occurred and been reported on of data breaches, there is no absolute security, but the system is pretty tight, and with the future enhancements, I think it will become even tighter. So I cannot say unequivocally that there will never be a data breach, but I can say that the likelihood is exceedingly low.
Thank you, Tracy. We've got a question for Dr. Karam here. What therapies, if any, are recommended for neuropathy caused by the chemo treatment?
Yep.
Dr. Karam?
Yeah, the chemotherapy is actually, one of the main problems in our practice and in patients with multiple myeloma. Neurological complications in multiple myeloma are possible, and we see them, but the main ones are really caused by us, the doctors, and with the chemotherapy. So there's different ways we manage this. Of course, we reduce the dose of chemotherapy or spread it or change chemotherapeutic agents. But today, there's no medication that one can take to prevent the occurrence of neuropathy, unfortunately. So once the neuropathy starts, we hope that with changing the regimen of the chemotherapy, the signs of neuropathy and severity of neuropathy will lessen, and the symptoms will become less disturbing to the patient. But unfortunately, sometimes we do have to rely on medication to just manage and mask the symptoms. There's really no cure for the neuropathy. It's mainly masking the symptoms. I hope that answers the question.
Thank you.
If it doesn't, we'll find out.
Another one that got a lot of votes was whether AL amyloidosis can morph into multiple myeloma. We know we have some patients that have both. So maybe for the...
That'd be a great question. Let's throw that to Dr. Landau, and then we can get some other thoughts on that. Let's throw that to Dr. Zonder. We'll get some.
Sure. Historically, we've always talked about how a subset of myeloma patients develop amyloid-related symptoms over the course of their illness. It's, the number depends on how hard you look, but a commonly cited number is 10 to 15% over the whole course of the patient's myeloma. We haven't talked about that as much in the other direction, and I think in the past it had a lot to do with the fact that amyloidosis patients didn't have the longevity that myeloma patients often do. But that's changing, and so as diagnosis is getting earlier, as therapies are becoming more effective, particularly non-transplant therapies are getting more effective, we have more long-term survivors, and I think all of us have seen patients who, after some period of being treated for only amyloidosis, do develop a more aggressive myeloma, more aggressive disease with myeloma symptoms. To be honest, just sort of speaking to what Heather was saying before, and Suzanne, the clone is in many ways biologically more like an MGUS or non-cancerous but clonal plasma cell disease. And just as in MGUS, patients sometimes, some percentage of patients progress to myeloma. I think we're going to see, it's not surprising that some patients with amyloidosis acquire additional abnormalities, additional molecular events or genetic events that end up leading to a myeloma course rather than just amyloidosis.
Thank you. And here's another question. Dr. Zunder, as long as you're there, we'll let you start with this. How long should Darzalex be continued if a very good partial response is achieved? Kidney involvement with no reduction in protein in urine. If in monthly treatment phase, will kidneys be protected from further deposits or should additional treatment be considered?
So that's a difficult question. I don't think you're going to get a universal answer on this. Right now, there isn't great data supporting the use of maintenance therapy in amyloidosis, but some classes of drugs like IMiDs, that's Revlimid and Pomalyst, and DARA is the other biggie, tend to be used on a longer term basis, either because that's the way they were studied and originally developed, or just because the toxicity profile in the case of Darzalex, the toxicity profile and the schedule, which is at that point monthly infusions, is attractive, compared to daily or weekly treatments. So in my own practice, it's kind of a mix. I think that I'm finding that most patients on Darzalex who have had a good response to Darzalex and get out to that sort of like 6-month mark where it goes to monthly, most of them don't actually want to stop taking it if it's working. And I think that there is at least a little bit of a difference between a very good partial response and a true complete response in terms of the likelihood of problems down the road. And so to answer that specific question, I'm inclined to continue Darzalex for that patient who you just mentioned, the one who has significant organ involvement and still has a small but measurable increase in the involved light chain. I would probably continue the Darzalex.
Thank you. Can we have another hematologist pipe in on that? Just unmute and speak.
So this is Vaishali Sancharavala. I agree with Jeff that it is very difficult to stop it if patients are responding because it is so easy to tolerate it. 2 prospective clinical trials, one at my institution and the other one in France. The duration of daratumumab therapy was very different. In my trial, which was an investigator-initiated trial, the duration of daratumumab was for 24 cycles, so for 2 years. Whereas in France, the clinical trial had duration of therapy was 6 months, so 6 cycles. Again, I don't really think that we have head-to-head comparison. Patients were different, and we are already seeing patients who have been off after 2 years of therapy, and some of them are progressing or relapsing with their hematologic parameters. So I don't think we really know what the duration of therapy should be. On Andromeda clinical trial, which is for newly diagnosed patients with AL amyloidosis, the daratumumab on one arm is continued for 24 months. So this is the data. We will see when the data on Andromeda mature, what is the right duration of therapy, if there is, and what to do. And then there is retreatment with daratumumab, which we don't know if patients had responded, we stop therapy, and then they relapse. Should we be retreating them with daratumumab or any other anti-CD38 monoclonal antibodies? Because now we have isatuximab as well available for at least myeloma. It is FDA approved, and SWOG 1702 trial has been completed to accrual and was to be presented at ISA in March, but hopefully will be presented in September now.
Thank you. And I want to throw something to Dr. Havasi, our nephrologist on the panel. Dr. Havasi, we're talking about all these treatments that basically go after the factory, the amyloid factory, to stop them from making amyloid. But are there any treatments that, of all the treatments that Dr. Landau has gone over and that we've discussed today, any of those treatments that you find kind of push the kidneys to start healing themselves quicker than others?
What the important thing is how quickly we can shut down the factory. So whichever works the fastest, that's the best. If we shut down the factory, then the kidneys are able to start recovery. And the recovery can take a long time. So I don't expect recovery in a week or a month. The mean time to recovery in the kidney, at least, so the mean time that we detect improvement in the amount of protein in the urine or the kidney function is, so the mean time is 10 months. So some people respond in 6 months, some respond in a year or two, but the kidneys basically recover when the factory is shut down by the chemotherapy or the stem cell transplant, what we are using.
Okay, thank you. Okay, Trace.
So, yeah, so I have a couple of questions maybe for the cardiologist again. So it's actually two groups of questions. One is about whether a pacemaker might provide some benefits to anybody who gets exposed to COVID-19. I don't know if that's even really known yet, but that was one of the questions because the impacts of the heart on the current pandemic. And the other one was a little more specific about drugs taken, which was metropropol and
yeah, right,
and amiodarone. I mean, if I
amiodarone, right?
Yeah, that one. I guess I need to practice the pronunciation of the drugs, or I need a. Yeah. Anyway, which is so. Those are two were mentioned as a low dose, and one of the patients was asking if these may be contraindicated with amyloid.
Okay. Well, let's go to Dr. Walensky to see if we can get him to see if his speaker's working now. Dr. Walensky.
He just texted me and said it's not.
Oh, okay. I'm sorry to hear that. All right, then let's go to Dr. Trachtenberg.
Sure, I'll take, so first with amiodarone and metoprolol, the issue is that that amyloid can infiltrate the conduction system of the heart where all the electricity tells your heart how to beat. So generally patients with amyloid are at risk to have that conduction system involved by the disease and at risk for having low heart rates or what we call heart block when the top chamber may not be talking to the bottom chamber. So in general, if we can avoid medications that slow the heart rate down, like amiodarone or metoprolol, we try to do that. Now, sometimes on the other side, patients with amyloid involving the heart have very fast heart rates and atrial fibrillation, and sometimes our hand may be forced to use these medications in low doses, and it's not ideal. It's not an absolute contraindication, but it is a relative one. I try to avoid using it if I can, but I do sometimes have to use it in patients that have a high burden of atrial fibrillation. In terms of COVID, the other issue with metoprolol, not just the heart rate, but it also can, it's a blood pressure medication, so patients with amyloid oftentimes don't tolerate blood pressure medications. So just have to be cautious in patients and make sure they're not dizzy or have orthostatic hypotension. In terms of COVID and pacemaker, I mean, COVID, we're learning to have, some patients do have a lot of cardiovascular manifestations. I haven't heard much about pacemakers and the need for pacemakers in COVID patients. If COVID attacks the heart to the point where they have, advanced heart block, sure, they might need a pacemaker, but that's not a common treatment for these patients at this point.
Okay, do any of our other cardiologists want to pipe in? You can unmute and pipe in if there's anything you have to say. Okay, well, Tracy, let's go to the next one.
Okay. The other one was maybe back to the, sorry, I was looking for the one I was trying to find, another one for Dr. Wall. It was about the expensive, yeah. So I found it. Okay, so the cost of the scan being expensive, and do you feel that the cost could be such that it could be used as a tool in seeing how patient is responding to either treatment or organ recovery as time goes on? So something that can be used in a different way in the future. But is it based on the cost? Maybe not.
So yeah, definitely we want, because the way we scan the patients, we think we are able to quantify the amount of amyloid in the organs. So being able to do repeat scanning and actually get a number for how your amyloid load is changing is something that we think is very doable. With respect to the cost, that's well above my pay grade, but I think the number of scans used per year will dictate the cost. If there are if it's well adopted, then the price will be much lower than if there aren't many scans done, because it's based on, with all radio tracers, the usage will dictate the cost, I think, in a lot of cases, and I think for this one as well. But I don't think it will be prohibitively expensive. We have estimates that it could be, if there's a lot of usage in the US, the cost could be $1,000 or less, which is, for a nuclear medicine scan, is very reasonable.
Yeah, thank you.
We've got a question here on CyBorD that I think.
Yeah, I was going to do that one next.
Okay,
yeah, so
do that one, yeah.
So how this talking about toxicity. So it says, how many CyBorD cycles rounds can a patient have overall? So this person had 11 of CyBorD, and considering Cytoxan is highly toxic, does it increase the risk of having MDS or any other complication from therapy?
So let's have Dr. Lynch answer this one. And yeah, the MDS comes up quite a bit, so you might want to explain that as well, Dr. Lynch.
Yeah, that goes back to the question also of maintenance. I think the main goal in AL amyloidosis is to induce a complete remission and, if possible, an MRD negativity. That means minimal residual disease negativity. I'm not a big fan of either maintenance or prolonged treatment. I usually give a certain number of cycles. If patients are in complete remission, I very often say, okay, let's give 2 additional cycles to make sure, to make sure that you are in a deep remission, and I do a bone marrow biopsy and check for MRD negativity, but there's no fixed cycle. And also, I'm not a big fan of maintenance. It depends a lot, and Dr. Sonder mentioned, if you have patients with relapse, multiple relapses, and you have a good treatment, you want to make sure that you keep them in this response stage. But in newly diagnosed patients, if they have a complete remission after 6 cycles of CyBorD, for instance, I would stop treatment.
And what about, tell people what MRD is.
MRD, minimal residual disease. You hear a lot about MRD testing in multiple myeloma. That means you take a sample of the bone marrow and you check whether you have traces of abnormal or monoclonal plasma cells. That means you look for detection of 1 abnormal plasma cell in 1 million of bone marrow cells. So it's a very sensitive method, either by flow or by next generation sequencing. And what we know from multiple myeloma is that patients who are MRD negative, that means they have the deepest remission we can measure, much deeper than a complete remission, that they have a better outcome. We do not have a lot of studies in amyloidosis, but what I think is we know that multiple myeloma, despite you have MRD negativity, is still a disease that you cannot cure. But I truly think that there's a proportion of patients with AL amyloidosis who are MRD negative. That means you cannot detect any traces of abnormal cells, might have a long-term remission, or might never need treatment again in their life. So I think the goal is the deepest remission, not the length or the number of cycles.
Okay, and another thing, when it was brought up, is MDS, which and we know that is a cancer, or sort of a pre-leukemia type cancer, that can be caused by too much chemotherapy. Is that what happens there? And how do we watch out for that?
Yeah, I never saw that in patients with AL amyloidosis. Usually patients with amyloidosis require less aggressive treatments, and I don't have cyclophosphamide on the kind of really high list of causing MDS. So it's not my concern, but Vishali, transplant, Jeff, Heather, what do you think?
So we haven't really, we have had several cases of therapy-related myelodysplastic syndrome, which was attributed mainly to oral melphalan and prednisone when it was used over a long period of time for 12 months, 11 months, 8 to 10 cycles. So I think with high-dose melphalan and stem cell transplant, we have not really seen it. But as patients do live long, we may be seeing certain percentage. And, I don't know if Shaji is still on, I don't know what the percentage in multiple myeloma from high-dose melphalan and stem cell transplant is for therapy-related myelodysplastic syndrome.
Dr. Kumar, are you still on?
Ariel, I'd like to jump in for a minute with a message from Dr. Walensky.
Sure.
He said, also reiterate that amino and beta blockers impair exercise training in these patients.
Okay, let's ask Dr. Ruberg about that.
And actually, if you could, I actually have a cardiac question. Maybe we can just kind of do it together. So this patient says, I've had some thickening of the wall of my left aorta in the past year, and my cardiologist here in, I assume, South Carolina, thinks it is from when I had amyloid sitting in my heart 10 years ago. And, oh my gosh, it just jumped. Sorry, it jumped to the bottom. That's the bad thing about the voting, is that if somebody votes and then it moves, which is good, but also
let's get him started on answering that first one.
Yeah,
Dr. Ruberg.
You mean the question of the exercise tolerance comment?
Yeah.
Well, definitely. I mean, those drugs slow down heart rate, and one of the kind of the features of light chain amyloidosis affecting the heart is that patients have impaired exercise tolerance. They get more short of breath with less exertion, and it can be significantly exacerbated with metoprolol, which is one of the reasons why we end up stopping metoprolol in the majority of our cases, actually, because of its effect on slowing heart rate and reducing exercise capacity. Amiodarone is a little more complicated because amiodarone does slow heart rate down definitively, but you start it only in very specific clinical settings. It's not a drug that a cardiologist would start, unlike metoprolol, because a patient may have coronary artery disease or evidence of cardiac injury or things like that. So, but I think the point about metoprolol is really well taken. I spend most of my time, instead of my colleagues, peeling away medications that were started that patients don't tolerate very well. Now, the other question you were asking, Tracy, did you figure it out?
Yeah. So it said, I actually took a picture of it. So I've had thickening in the wall of my left aorta for the past year, and my cardiologist here in South Carolina thinks it's from when I had amyloid sitting on my heart 10 years ago, even though there was no detectable damage at that time. He said, we'll still just watch it. And what do you think?
I'm wondering if the question refers to the left atrium or the aorta. I don't really the left aorta.
The left aorta. So I had some thickening of the wall of my left aorta in the past year.
Well, the aorta is the blood vessel, as showed in my anatomic figure, that comes out of the heart, and there is only a left aorta. There isn't a right aorta. So trying to make sense of that question. The aorta definitely can become thickened in the setting of atherosclerotic heart disease. That usually you see that you have to do special imaging to see that, like a CT scan or a transesophageal echocardiogram or an MRI. Not really visible that much by echocardiography. Left atrium is definitely something they could be referring to. That may be what the question is referring to. And left atrial the septum, the dividing area between the atria, can sometimes be thickened in amyloidosis. Also can be thickened in other conditions too. But it sounds like if that imaging observation is not associated with any significant pathology, I would agree that following is the right approach.
Okay, let me just, yeah. I had a few questions about back, maybe more of a hematologist question about kappa and lambda, because one person said that if AL patient has both kappa and lambda elevated at diagnosis, should treatment somehow be different from conventional therapies of AL? I had also some questions about, okay, what's the difference between lambda versus kappa-based amyloidosis? So Muriel, do you want to?
Oh, let's have any of
somebody. Okay. Sorry, before we do that, I have a text. I think it was the left ventricle. Maybe does that help on the cardiology question? I just noticed had an echocardiogram talking about the left ventricle. Does that maybe add to it or help?
Well, so maybe I should let one of my other cardiology colleagues comment, so I'm not kind of hogging the spotlight here. So I'll that does change the meaning of the question, and I'll defer and sit back.
Okay, let's hear from Dr. Sperry.
All right, thanks. So I guess the question is if the left ventricle is now thickened, 10 years after an amyloidosis diagnosis. Yeah, I mean, I think that's a good question. The left ventricle can be thickened for multiple other reasons, including high blood pressure. So, I mean, that's something you need to think about, as well as some other cardiac disease. But, you know, certainly you need to, if you're seeing thickening of the left ventricle, you do need to think about recurrent amyloidosis. But I'm sure that, you know, your doctor is monitoring light chains and immunofixation and everything that they're supposed to be monitoring. So the other thing is that it's oftentimes difficult to measure the left ventricle, and there can be some differences on echo from year to year, depending upon the views that they get and how people measure things. Oftentimes a cardiac MRI gives you a little bit more accurate information as far as whether or not the left ventricle is thickened. But you know, without giving too much medical advice, I think it, you know, if you're not having symptoms and if everything else looks okay from an AL amyloid perspective, then I think it would be reasonable to keep an eye on it.
Thank you. Shall we return to the question about the lambda versus kappa? So if somebody has both involved, yeah, go ahead. Thank you.
It's actually pretty unlikely that both would be involved. I mean, it's possible to have biclonal plasma cell diseases, but that would be an extremely unusual circumstance. So usually the biopsy will tell you whether kappa or lambda is the culprit light chain. And that's the one that's more important to get reduction of. The most common reason that both are elevated actually is renal insufficiency. And so if your kidney function is abnormal, you may have baseline elevations of both. One is typically more elevated than the other, and you're still concerned about the gap between that involved light chain and the uninvolved light chain. And you should probably consider the level of the uninvolved light chain as your floor, like what you're trying to get the involved light chain down to in that circumstance. I don't know if the hematologists agree.
And just as information here, the person, it's anonymous, but the person mentions 40 milligrams per deciliter for kappa and 160 milligrams per deciliter for lambda.
Right, so those are, so again, if it's milligrams per deciliter, and it's a free light chain test, not light chain measurements on a serum protein electrophoresis and immunofixation. If it's a free light chain assay, you know, both of those are quite abnormal. The normal range is, you know, roughly 1 to 2 milligrams per deciliter. And so, you know, both of those are very elevated, but also that is still a significant skewing of the ratio, and the lambdas are elevated way out of proportion compared to the kappas in that situation. So my guess would be that the lambda is the culprit, but again, the biopsy should confirm that.
Okay. We've got some questions. Would one of the doctors explain why we are prone to bruising? Now, we don't have I think any one of our brilliant hematologists can answer this one. All right, a brilliant hematologist, Kara Rosenbaum. Heather Landau. All right, we'll take Dr. Vestio.
All right, thanks. I think I'm not exactly sure why people with amyloidosis have more bruising. It tends to deposit in the parts of the body where the amyloid is more pronounced. So that's around the eyes. But it is definitely a feature. And as you correct the condition and kill the cells so they don't make any more amyloid, then typically the bruising gets better, but it takes years to get better. And then I just want to go back to the last question because I think it's an important thing to notice. That result may be the total light chains. And unfortunately, when people get light chain tests and they go to a clinic and it gets typed in, oftentimes what gets measured incorrectly is the total light chains and not the free light chains. And so you really have to look at what they consider normal, the normal ranges, and normal ranges for kappa are either going to be 19 or 1.9. And if they're not, they don't say that in the reference, like what they consider normal. It's probably the wrong test. And I've seen many times doctors getting tests and decisions being made on the wrong one. So it has to be the free light, the serum free light chain, not the total light chain.
Okay.
Going back to the bruising question, probably vascular deposition of the amyloid. When we do biopsies, a lot of times what we're actually looking for, even in the fat biopsy or bone marrow biopsy, are looking for amyloid deposition in the blood vessels. And so that may make them more fragile. There's also a subset of patients who have a more significant bleeding issue, and it's not usually the bleeding or the bruising around the eyes or the bruising on the arms and hands that we see very commonly in amyloid, but it's an actual bleeding disorder because for some people the amyloid deposits sort of sop up clotting factors, and you have some patients who have deficiencies of clotting factors almost like they have hemophilia, and those patients can have real bleeding issues. That's a small minority of patients. Usually it's the bruising.
Okay, you know what I think we ought to do, folks? Okay, we could obviously go on all afternoon, but that's not fair to anybody. Well, although we all think it would be very fair, but nevertheless, the doctors, it's not fair to our doctors for sure. So, and we still have 228 patients that are listening and hanging on your every word. So I think if we promise them another meeting real soon, okay, I think, and hopefully we have all you doctors on board for doing another meeting real soon. So can we all have you turn your speaker on and tell us that you will be willing to do this again?
This is like sitting in the exit row on an airplane.
Yes.
Right.
Remember
time
for airplanes, and
Yeah.
they say that, yeah.
Yes, you have
But
to
yes,
say yes.
yes, I can do that.
All right, everybody else,
Yeah.
I want to hear yes.
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 Cardiology question.
You gonna take a roll call
next week?
Okay, so we're going, okay.
There was a comment about next week, so I think it's also important. I mean, this is an AL focus, but was mentioned also the cardiology stuff will also be covered some next week.
And I think we learned a lot from today. Okay, I know you want to all join and everyone out there and everyone here and everyone in our control and thanking our physicians and scientists for taking time out of their schedule. I admit we're rather spoiled and we're kind of used to some of these doctors giving up their whole weekends and hopping on a plane and staying in a lonely hotel room and leaving their families just for you folks out there. And not that we expect it or take it for granted, but we appreciate it so much. And we really want to say a big thank you for today. We don't take you for granted. Okay, we probably don't thank you often enough, but we know what you do is unprecedented in any disease, let alone a rare disease. We'll be doing another one of these very soon. This is what, April? We'll be doing another one in May, okay?
Sounds good.
So I promise everyone will do one in May. And any of the glitches that might have happened today, we're learning, okay? We'll be experts for the next one, I'm sure, although that'll probably have a few of its own glitches as well. I do want to add that we'll be doing a meeting like this for our ATTR patients next Saturday. Some of our cardiologists and neurologists and other amyloidologists will be on that meeting as well. This will be for our wild type, our hereditary, and our non-ATTR hereditary, such as our Gelslin, our fibrinogen, our ApoA1s, our, so anyone who doesn't, and even our ALAC2s, even though that's technically not hereditary, we're going to include them in that bunch too. So we'll let you know when this meeting is available online. We're learning that too right now. Okay, we're in the process. And I want to take time to thank all of you for joining us today. I want everyone to take care. And let's have everyone that's on here, all of the ASG people and all of our doctors individually say some farewell words. I think that everyone would like to hear that, okay? Who wants to be first?
Thank you so much for being here, everybody. We hope you have gotten something out of this today. I know I learned a lot more information that I'd never heard of. Got to meet doctors I'd never met before. So I think it's been wonderful. Thank you so much. And hopefully we'll see you out on the road in a few more months, maybe. Who knows? I'm out from Georgia.
Thank you, Paula.
Thank you all. Great talks today.
Thank you so much. We really appreciate, Dr. Sperry, your joining us.
Yeah, great discussion.
I'm sorry that I had logistical issues, but if you have
now we can talk.
Speaks words.
We need Dr. Walensky to talk because he's giving our presentation next week at our TTR meeting.
We finally got it to work.
Great.
That's good. That's good. It was a prep for next week.
Proves we're live.
Yes. Thank you, Dr. Walensky. Who else is going to say goodbye so we can give him a personal goodbye there?
Fix the kidneys, and I'm going to go back to the hospitals to try to fix some kidneys.
Thank you. I mean, you're in Boston. We know you're very busy right now. Well, all of our doctors are busy, but I know Boston and New York are extra heavy. So
yeah, unfortunately. So
good luck to you all.
Bye, everyone.
Bye.
Bye. Bye.
And Dr. Picken, thank you so much. Really appreciate your coming. We may have had some questions for you, but we didn't get to them, but we will next week, okay?
Next time. Next time.
Thank you so much.
Thank you.
Thank you. Bye-bye.
Oh, Dr. Lynch, thank you so much. We really appreciate it. Bye-bye.
Take care. Bye-bye.
Okay.
Bye.
Okay, and
I'll say goodbye.
Oh, Dr. Ruberg, thank you so much.
Thanks, everybody.
Bye.
Be safe, everyone.
Bye-bye.
Yeah. Bye-bye.
I'll just add that it's my first time doing this. It's great to have so many patients actively engaged in their disease and asking great questions. So it's a kudos. Thank you for having me.
Thank you.
Thanks, Dr. D. Thank you for such great talks. I always learn about the hematological aspects of the disease from these. So thank you to the speakers, and I thank all the audience. I think they're from all over the world. So I know there was at least one from South Australia. So
there was one from Perth. We definitely had a Perth on here for sure.
So stay safe.
Thank you, Dr. Patel.
Thanks, guys. Thanks, Muriel. I appreciate this. I only got a few comments about my wallpaper privately, and now I'm going to go to my fridge and enjoy the afternoon.
Oh, thank you, Dr. Ball. We will definitely see you next week at our TTR meeting. Yeah.
I will be there next week. Thanks, guys. I appreciate it.
Bye-bye now. Thank you.
Bye.
No corona.
Okay, we're going to say, who else are we going to say goodbye to?
I'll say goodbye. Thank you so much for allowing Caitlin to be a part of this. I'm always in awe of the people that cardiologists, nephrologists, hematologists, and people that devote their life to this patient population. So hopefully we can play a part, and anytime you want industry participation and understand about our trials, I'm happy to participate.
Well, you are now an honorary member of our family. Thank you.
Thank you.
And who else are we saying goodbye to?
Dr. Vesio.
Oh, Dr. Vesio.
Oh, thank you very much for putting this on. This was an outstanding meeting. It was very well done, and I learned a lot. So thank you very much.
Oh, and we appreciate your coming so much. I miss you. I miss all my California people so much.
Yeah, well, we'll see you soon.
I hope so. Take care, everyone. Oh, okay, and then we're going to say goodbye to Heather.
Yes. Hi. I just want to say I echo his words. This was a great meeting. And your efforts, Muriel, to get all of us and to get everybody together to educate the community are invaluable.
Heather, hang on for a
minute. I just wanted to make one more comment. I hope that you all understood that these drugs that I spoke about, I just want to say one disclosure that these are not FDA approved, if I didn't make that.
No, I think you make that very clear.
Very obvious, but these are being studied, and there's hope for our AL patients.
Don't sign off yet. There's something I want to talk to you about, okay? Don't sign off for a second or two. Okay, who else have we got? Dr. Karam, we have you on here, and Dr. Trachtenberg, we have you on here, so we'll say goodbye to you.
Yeah, thank you very much. I'm sorry I had to start preparing lunch for my family, but I really enjoyed this very much, and thank you very much for having me, and I hope I was helpful.
You were wonderful. Thank you, thank you, thank you. And Okay, so who else do we have on here? Do we have any of our doctors left besides Heather? Heather, okay, Dr. Karam didn't. Dr. Karam, you didn't sign off yet, but that's okay. Heather, I wanted to tell you, Dr. Karam knows this anyway, but
we still have 123 participants.
Oh, okay.
I was going to say, whatever you say, Muriel, is still recorded as part of the whole program.
Okay,
so
I don't
if you want to have a private discussion, then I would suggest that we close and you call her.
Okay, that I will do that. I will. Yeah, I will do that, Dr. Landau. Okay.
You have my phone number. You can call me.
Oh, I think I do, and if I don't, I'll send you an email. How's that?
Perfect.
Okay. Thank you so much. And
okay. Thank you, everybody.
Yes. Bye. Bye.
And special thanks to Bob.
Yes.
Oh, you're welcome.
For putting
it was
this
a great
all
presentation.
Together.
Doesn't he look professional with his...
I'll make sure you get a copy of it too.
Okay. Take care.
Bye-bye.
Bye.
Everybody be safe.
You too.
You too. Stay healthy.
Okay, so we will send copies out to everyone when we get ourselves, a little bit more organized. We will get that done, okay? And we will have another one of these in May. And Bob and Tracy and Paula and all of us, we're going to really study up hard on this, aren't we, guys? Yes, we're going to. Although I thought it came off pretty well myself, but what can I say? And there's 95 people still left on this. We want to thank you for joining us. We will let you know when the next one is. We'll have the doctors that from today that we're on that can come back, and we'll also have some new doctors. Okay, we realize. And if you have any suggestions on doctors that you'd like us to have, send us an email. Send it to Paula at amyloidosisupport.org. Okay, thank you so much. Okay, I'm ready to sign off, everybody. How about you?
Yep.
Yeah.
Yep.
Okay, so I hit the leave meeting, right?
Yep. Yep.
Okay.
All right. Bye.
Okay, that's it. Thank you all for joining.
Thank you.
The webinar is now closing. Bye-bye, everybody.